more minute to allow folks to log on, but we didn't want to leave you out there in the waiting room. So just give us one more minute and we'll get going with our agenda. Christine, you have the admits. Are you handling that? All right. So why don't we do have a very packed agenda this afternoon. So let me get going with some introductions while others join us. So first, I just want to say welcome to those of you who are joining us this afternoon. I'm Janice Tondora. I'm the PI and the co-director of the New England MHTTC, and very pleased to have you all here with us for our topic today around person-centered advanced crisis planning. And I'm just going to say a few introductory housekeeping remarks to sort of set the stage before I turn it over to our panelists for this afternoon, who are going to be leading our presentation. So we always just start with our standard acknowledgement and disclaimers that this is a SAMHSA funded project. New England MHTTC is funded through a cooperative agreement. And while we feel very strongly that today's topic in the PCRP, Person-Centered Recovery Planning Consultation Corner, in general is in alignment with SAMHSA's principles and their strategic plan, the comments in the material today do not reflect any official DHHS or SAMHSA position and belong to those of us who are participating. If you're not familiar with the MHTTC Mental Health Technology Transfer Center Network, we are a series of 10 regional centers around the country who are funded by SAMHSA to support the implementation of evidence-based and other innovative practices across the country. This particular webinar series is brought to you in a co-partnership between Region 1 in New England, that's our region, and our partners in the South-Southwest down in Region 6. Both of our regions happen to have a particular focus on recovery-oriented, person-centered, and really lived experience-informed approaches that we think is very much in alignment with today's topics. This is just a quick reminder about the language principles that we apply consistently throughout the MHTTC, including today's presentation, really trying to be cognizant of always consistently using affirming, respectful, recovery-oriented, person-first language throughout our materials and our webinars. A few quick housekeeping items. I don't think we've ever had to shut a webinar down, at least not in my tenure, for security reasons, but we do have the ability to do that if needed. If we have any uninvited guests, if that ever were to happen, we would follow up via email. You do have the ability to raise your hand, to unmute, to share. You can also please actively use the chat box. We're going to be holding questions until the end, just because we do have 3 different panelists that have really great information to share, but feel free to use that chat box. We're going to be monitoring it for questions to try to get to those at the end. You saw likely that you had the pop-up that today's session is going to be recorded. You will get follow-up information from a South-Southwest email address around getting your CEU certificate. Please just remember, keep in mind that your CEU certificate is based on participating in the full event, based on your Zoom participation log. And then each participant can then follow up with their respective licensing boards and whatnot in terms of the processing of those CEUs. So I am going to allow each of the presenters, when they kind of step in to cover their section, they're going to tell you a little bit more about their background and what they're bringing to you. But I do just at least want to say that I'm really excited about today. I think you're in for a real treat and some thought-provoking conversation. you know, Dan and Amy and Marvin Schwartz, they bring just a wealth of professional and lived experience to the table, and have a bunch of different tools and resources to share with everyone. So I'll let them say a little bit more kind of when they step into the spotlight. But before we go any further, we do just want to get a sense of who is in the audience with us today and kind of what hats that you're wearing. This can be sort of multiple choice. We realize that people sometimes wear lots of different hats when they attend these trainings. So Christine's going to go ahead and open a poll just because it will get a sense for us of who's with us and how we might kind of tailor our remarks to be responsive. So we'll give you a minute to do that. Christine, looks like we're hitting a quorum here. You want to go ahead and share the results? All right, folks, see that? We're okay with the technology? All right, so we have, wow, this is probably the most diverse audience I think that we've had in this series, right? So I'm so pleased to see we've got a lot of peer support specialists, people who are in direct support roles, family members, nice representation from leadership, and people with their own lived experience, right? Okay, so I think that we have built something for everyone that's going to appeal to all of our audiences, based on who's with us today. But let me just say a couple of things before I turn it over to Dan, who's going to be our first presenter. So this is just the definition of person-centered recovery planning, PCRP, that we've been using in this webinar series. You see the emphasis on the collaborative process between a person and their chosen team, right? With that team, including both behavioral health care providers, but also any chosen natural supporters that they're seeking to involve, to really kind of come together and co-create an action plan in alignment with that person's unique recovery goals, right? And their vision for the future. And that applies at all points in the process, including at moments of crisis, which we're going to talk about in a minute here. So if this is the first time that you're joining us, just to give you a little bit of context, we are in the fifth, this is number 5 of 6 webinars around frequently asked questions, around person-centered recovery planning. We've covered systemic issues, we've covered practice-based issues. Today, we're here to talk about person-centered advanced crisis planning. Our final webinar next month, feel free to check us out. We're going to talk about a variety of leadership, organizational, quality improvement, supervision strategies to really reinforce and sustain quality PCRP over time. I just also want to make sure that you are all aware of a resource that recently came out from SAMHSA. It was a comprehensive issue brief on person-centered planning. It was written specifically for leaders and organizational leaders to really align policies, procedures, culture, financing, service eligibility to align large organizational systems, including state mental health authorities, in ways that actually support good person-centered recovery planning. And I actually had the opportunity to work with a small group of people to take the lead on drafting this report. And I will tell you, we worked very hard to embed all of the best tips and tools and resources that are available around the country. So it's really packed with a lot of resources. Just wanted to make sure that you're aware that this is out there, and encourage you to check it out. And so before I let Dan introduce himself and say a bit more, I just want to say that part of the reason it was important to me personally to build this topic into our webinar series is that in all the work that I do with states and systems around the country on person-centered planning, sometimes even really highly skilled and highly committed practitioners and leaders really struggle to maintain their person-centered stance in moments of crisis. And sometimes I honestly see it fly out the window at those moments. You know, when people are really concerned about someone's safety or well-being, or concerned about the safety of those around them. And so there is this tension around how are we sort of maintaining and supporting safety, but also kind of maximizing choice and control and autonomy. I would actually argue that it's at a moment of crisis that it may be the most important point in time to be thinking through a person-centered lens, because frankly, significant harm and trauma has come to people in those moments when we abandon sort of our person-centered thinking and tools. And there are actually a wide variety of tools and strategies that are out there to really protect people's rights and autonomy as much as possible, but at the same time, being clinically responsible around safety concerns during times of crisis. And that's what you're going to hear about from our three presenters today. So again, many thanks to all of them for being here. And without further ado, I'm going to turn it over to Dan.
All right, there we go. Thank you, Janice, and welcome everybody. I'm really excited to have you here with us today, and I was really excited to be invited to participate in this. Just quickly, just a little bit about me. I'm still a practicing psychologist. I worked in New York, Connecticut, Rhode Island, and spent about 20 years collaborating with Janice, where I had various roles in different agencies. So I'm going to try to bring to you today the perspective both as a practitioner and as someone who's worked in different parts of the system in different roles. So I've had a very significant role in quality, had to be responsible for like joint commission surveys, have run both inpatient and outpatient facilities, was a CEO at one point. So I think I've seen this work from a number of different perspectives. And I'd like to just try to highlight one, just kind of some of the systemic pressures that come to bear when trying to work with a crisis and continue to be person-centered. As Janice suggested, I think there is a tension there that can be resolved, but you need the right tools and you need the right approaches. Okay, so that's where I'm going to focus. So, Christine, if I could have the next slide, or Janice, whoever's flipping them. There we go. All right. So when it comes to a crisis intervention, what is the outcome that you're seeking? Okay. And what is the outcome that you're seeking within a person-centered, recovery-oriented system of care? So first and foremost, and you will hear this from everyone, is that you want to keep everybody safe. Okay. So whatever that crisis might be, it certainly implies some danger or harm or something bad happening. So the efforts and the change in focus and approach gets ramped up to try to prevent it from happening or lessen the effect. Okay, so the services and the service packages change at that moment in time to try to bring it to bear on the crisis. Okay, so goal number one, keep everybody safe, minimize the harm. At the same time, you want to respect and honor the person in crisis, their needs and preferences. And that's where the person-centered approach comes into play. And there are a number of tools to do that. I think all three of us are going to talk about those tools today. And there are a number of best practices out there that really can be used and have been proven to be effective. Okay. What you're looking for is some collaborative solution. Okay. that cannot always be attained. Okay. So when we talk about an involuntary hospitalization or any sort of involuntary solution, to some degree, you've not been able to reach the collaborative solution. Okay. And I just want to remind folks that what we're striving for is that collaborative solution first. My experience in many different settings is there's a tendency to jump to involuntary solutions without fully exhausting all the possible collaborative solutions. Okay. I'm going to talk in a minute about why I think that happens, and then what we can do about it. But again, I don't know about you folks out there, but in my experience, again, in different roles, I think when people start to get uneasy that there's some potential danger involved, there are sometimes steps that get skipped, and you get to a involuntary solution, perhaps prematurely. Okay. And as Janice mentioned, this is a big deal because these involuntary solutions can really do some real harm and cause real trauma to people, and can, I have seen many times that it just utterly disrupted what had been positive therapeutic relationships. Okay. Next slide, please. Okay, so why does this happen? So one factor that I think is important is, what's a crisis? Okay, there are legal definitions, there are societal definitions, there are local agency cultural definitions. So let me just give you a couple of examples. Okay, a person has reported to you that they are feeling, they've had some fairly persistent suicidal thoughts, and they've thought about how they might want to hurt themselves and started to hoard some medication. Okay, so is that at a crisis point? Okay, another example, person who in the past has have trouble binging with alcohol, and when they binge on alcohol, they put themselves in very high risk situations, and they've been clean and sober for a year, but they are starting to drink again. Okay, so I think my point is sometimes it is not so clear what is a crisis, and it's really important because some of these things, when do they kick in? Okay, so Amy, both Amy and Dr. Schwartz are going to talk more about this, what the definitions are, and what gets triggered when. Okay, but I think, again, in my experience, it's often something that is not, there's not a really firm definition on it, and there's not a great structure to sort of make those decisions when the situations come up. Okay, so what else? So again, I think 99% of the people that I've worked with have a genuine desire for people not to come to harm. Okay, so if for example, in the situations that I just described, people will do what they can, and I'm talking largely about the practitioners, to see that no harm comes to either the person they're working with or other persons around them or in the community. So that, that desire to prevent harm is, I think, positive, but the danger leads to a kind of paternalistic approach where you're stepping in and you start to try to make decisions for people that they don't want made. Okay. The next piece is, we're in a very litigious world, and people are cautious. CYA, I think, does everybody know what I'm referring to there? starts with cover. So it's, you don't want to be the one that didn't act. So that, I think, leads to a more often than not a more cautious approach. I know I've done it myself, where it's like, let's be safe. Okay, let's be safe. That's probably the quote. And again, I, a helpful thing, but again, if it goes too far, you can start to impinge on people's rights. Okay, there is a process that every agency deals with, and there's a tension. Okay, so if people who work in agencies may have been involved in what they call critical incident reviews, the Joint Commission talks about sentinel events. There's failure mode effects analysis. There's a lot of processes that are designed to understand and hopefully prevent reoccurrence of bad things, bad outcomes, people getting harmed. Okay. But at the same time, as you're doing this, you're trying to support their staff. Okay. So, if someone has harmed themselves and you have your critical incident review, I have seen staff who basically left the field after this because they could not, it was too much. They didn't know, they felt responsible. So you want to support them, but at the same time, you need to find out what happened so it doesn't happen again. Okay. And again, I bring this up as attention, all of these attentions which tend to make people more cautious. So if I'm not the one involved and I'm sitting at one of those critical incident review meetings and I'm watching that's, a lot of questions are being asked, I'm maybe thinking, I'm just going to be careful here. Okay. I don't want to be that one that's responsible. Okay. And the last thing I will put, one of the things I did was we implemented a zero suicide program in Rhode Island. And one of the central tenets of that is your staff have to be trained, confident, and competent. Right? So again, the less confident people feel in a crisis situation, the more likely they are to take the more cautious approach. Okay. So you, either as a practitioner or as the administrator or as a supervisor, our job is to make sure people have the best tools to bring that confidence up and to bring that competence up and confidence up. Competence and confidence. And I found that to be a really critical factor. Again, the less confident, the more cautious. Okay, how am I doing here? All right, good. Next slide. Okay, so I want to give you one tool. Again, we're going to talk more about some of the other tools, but this, I think this is a little different because this happens prior to any involuntary action, okay? Or in a way, it prevents involuntary action. So one of the, like I mentioned, one of the things that I was involved with was the implementation of a zero suicide program. And one of the, there were a number of best practices, and to me, zero suicide it's largely an accumulation of best practices. And I know there's some controversy about even the name, but there are a lot of really well-researched and effective practices that are sort of brought together under the zero suicide header. So let's not get stuck on the name for a minute. So again, universal screening. So you're asking people and you find out early on before something hits a crisis point, and you're able to intervene and still maintain all that collaboration and all that person-centered approach that you've been able to establish. being able to properly assess when the moment comes. There are tools for this, and there are evidence-based tools. And what I want to talk a little bit more about is collaborative safety planning. And actually, as we go on, you'll see there's some overlap in this, in like a RAP crisis plan and some of the other tools. But the idea is, when I was being trained, it was called contract for safety. Okay, so can you come to an agreement, that we are both comfortable with, me as the provider, you as the person in crisis, for a method to stay safe without having to go to some involuntary intervention. Okay, and this is really the evolution of that. Okay, that can we, again, me as the practitioner, you as the person who's experienced some crisis, come to some collaboration about how you're going to stay safe. And I found this to be useful both as an assessment tool and also as an intervention. Okay, and again, just some of the one kind of the most frequently used and considered the gold standard is the Stanley Brown Safety Planning Intervention. I put the link right up on the slide there for you to go to. That's in public domain, and they have wonderful training around it. It's just really well done. But again, so what does it include? So together we sit down, again, around the time of crisis, right? Can we recognize what your warning signs are? Can you employ internal coping strategies? What are they? Utilize social contacts to distract, or family and friends who might help you resolve the crisis. Who would you contact? And also the reduction of lethal means and making the environment safer, and then identifying reasons for living. And a question also that I would always ask is, how likely do you think to use this? Okay, because some people, it's interesting, we could go all the way through, have a great plan, and then when you ask, it's like, I don't think so. I feel too overwhelmed. Okay, so anyway, this is just one example, but there are a number of great tools out there so that you don't have to get to that moment of involuntary intervention. Okay, how did I do? All right, 2 minutes to spare. Not bad. All right, I am gonna hand off to Amy, and thank you all.
Thank you, Dan. I really love that conversation. I love the way in which you shared what you were sharing in that place where you don't have to get to the place of involuntary, right, intervention. And for me, my name is Amy Pierce. I'm a mental health peer specialist, and I'm also an advanced level RAP facilitator. I've been doing work in the field, in the peer specialist field, since about 2000. But here today, kind of the role in which I'm here and in the space of is a personal lived experience. A person who not only has utilized wellness recovery action planning in my own life, but has used it as a tool in implementing strategies at organizations that I've worked with, walking alongside other individuals who are creating their own plans, and really looking at how does this curriculum, this way of life, these conversations support peer specialists to really be able to stay in their role, and also really support person-centered care. For me, I currently work and provide technical assistance to a number of different organizations across the state of Texas, working on different recovery-oriented projects that they're doing. The cool thing is, just a little bit ago, I was actually talking about RAP and working with some of them around RAP and Wellness Recovery Action Plan, and what it actually brings and can bring to an organization. You can go to the next one, Janice. For those of you that don't know, there's a lot of different definitions of it. You may have seen different statements. I kind of like this quote, but Wellness Recovery Action Plan has actually been around since the late 90s. And I think it's important to note how it was created and in concept was a group of people actually came together up in Vermont, really looking at what they called these strategies. And they were talking about what's now called the key concepts. There wasn't anything around a crisis plan. There wasn't anything around any of the actual structure that we know today as a RAP plan. RAP itself is the tool. And I think it's very important to think and look at that the tool is just really part of the conversation. You can go to the next one. Wellness Recovery Action Plan really is this powerful process, this very simple process that can support individuals in creating the life of wellness that they want. It follows up a lot of what you were saying, Dan, and kind of that last tool that you were looking at, where a lot of actually looking at the plan spends time not just looking at that crisis plan, what should I do in the space of crisis, but most importantly, looking at what do I need to do for myself, right, to stay well? What can I do for myself to stay well? And the crisis plan comes into play if I end up in a space where I'm no longer able to do for myself. And should I end up in this place of crisis, I now have a tool where my voice can be heard, where my wishes hopefully are heard, and people actually know what to do and how to support me, where maybe in the past, they just haven't known. I know for my family and for friends, for me, when I actually first stepped into creating my rep and figuring out what this was, I did a lot of self-discovery. And in that self-discovery, I started finding language that I was able to use to express experiences that I had. And then also ask for the supports that I needed where I hadn't been able to do so prior. Once again, this is just a tool that people can utilize, and it's a larger conversation. Do you want to go to the next slide, Janice? You don't have to go to the next slide. We can stay here. Oftentimes, people hear of RAP as an evidence-based practice. And oftentimes, what I see at times, persons actually implement like just the crisis plan or just the piece of paper that has the crisis plan prompts because it's attached to that evidence-based practice. We're going to put in the chat the actual research around the evidence-based practice of RAP here in a second. And it's actually really interesting to kind of read, I think, and look at. The evidence-based practice of RAP actually comes from the RAP peer support model, which is a weekly, bi-weekly, monthly group type circumstance where persons really spend time going through key concepts, wellness toolbox, creating the RAP plan, and kind of moving forward. So it's not just a kind of a one shot and done. It's this whole place where people come together in a space of mutuality where they share and they talk, and they're able to start finding, like I said, that language, but also start to discover for themselves that they actually know more than they might think of what they need to do to help themselves stay well. And that's kind of the beauty that I find in this. I know we're talking really about crisis plan today, but I think it's important when we start thinking about and looking at person-centered planning process. What I found is that RAP actually can be an incredible tool to inform that person-centered planning process because people are able to kind of go on that exploration journey, kind of be a self-discovery find what they want to do, find what's working in their life, what's not through some of the activities, so that when they actually go into the person-centered planning process, they're able to state, like, I really want to go back to work, or I'm really wanting to get a house of my own, because I've kind of figured out through this process that living in an apartment and hearing those noises is really difficult, because hearing the noises of the other people next door has me be on constant alert, thinking that I'm hearing things that others aren't, even though it's the people next door, right? Go to the next one. RAP is based, like I said, there's the RAP plan, and there's what we call the study of mental health recovery, including RAP, and that's that whole package. And in my experience, once again, I am a advanced level RAP facilitator, so I train facilitators. People get the most out of this work and out of this tool having gone through the whole of it, because each part builds upon the other to support you to get to the place where you're really looking at that crisis plan and able to really fill it out in a meaningful way, in ways that really will support you should you be in the space where you need others to take over for your care. Because if you look at this, the key concepts are based upon hope, right? The belief that challenges, difficulties, like, they're here, but that you can get well and stay well for long periods of time, that I can meet my goals. It's based upon personal responsibility, right? That it's up to me to do certain things to take care of my well-being. It's about education, and education not about my illness, but about what supports me in the life that I'm trying to live, what supports me to understand what I may need. What does it look like? Should I be getting into places where I may not be doing as well as I'd like? The place of self-advocacy, asking for what I may need, speaking up for what works, and exploring that place of support. And all of these really are foundational going into not just the plan, but especially the crisis plan. Go to the next one. Many of you may have kind of seen this. You've probably seen either just some printouts or different forms in which the RAP crisis plan shows up. This is what we call it's the RAP on the go crisis plan. And it's basically a pocket-sized tool that unfolds that people can keep with them at all times. When we talk about RAP, there's a couple of things I just want to be intentional to say. RAP is always voluntary, right? It's always created for a person to share as much or as little with anyone that they choose. Some people may choose to share their whole plan with their care providers or their family or supporters. Others may just choose to share their crisis plan with those that are on the plan. Or they may share it with others just for a place of knowledge. As you were talking about, Dan, which I love, crisis is defined by the individual. What does crisis look like for me? Because what I may deem as a crisis may not meet that threshold that the organization may deem as a crisis, and it's a place that I may not have learned how to navigate yet, and I need people to step in, right? Crisis also might not look like something that we look at specifically around a mental health challenge, but could lead to a mental health crisis. One of the RAP plans that I created was one actually around moving. And I was leaving the city that I lived in for a number of years, where I'd really found my feet, found my foundation, found my wellness. And I created a whole RAP plan around it, but I also created a crisis plan around, like, what did it look like if I wasn't ready when the movers came? Because it gave me a lot of unease. And I knew how I was, and I knew that how I usually interact in life, that if that time got close, I shut down. And so in creating that crisis plan for that circumstance, I wasn't ready before the movers came. And my like set point was this, it was like 4 days or 5 days before, that if I wasn't a certain percentage packed, that my crisis plan went into action. And when it went into action, I had people and supporters on there who had exactly knew what they needed to do to support me, which included someone driving down from Lubbock, telling me step by step along the way, like what to pack next. And that may seem like not a crisis, but in my life at that time, I wasn't able to move. And I literally was getting in the place of what I call the swirl that was taking me to a place where it was scary. But having that plan going into that, I felt this place of comfort, right? You can go on to the next one, James. And I say that because I'm going to kind of show you two different things here. But I wanted to like mention that right there before I talk about how a crisis plan may look like really being enacted. What I have on the screen are the current prompts of RAP, the structure of the RAP crisis plan as it relates to the evidence-based process. And this crisis plan, it was created many years ago. It was created when RAP was very targeted around mental health challenges and what it looked like for people. So you can see by the prompts, it's very specific around like how am I unwell, when do I need supporters to step in, supporters, but medications, treatments, respite, hospitalization, and help from others in activating the plan. And if you'll go to the next one, Janice, this is the new language that they're using. And they're using new language because it opens up a space where oftentimes persons had a challenge seeing themselves within that initial structure. And within the new structure of the RAP crisis plan, it's just more open, right? It's more open where persons navigating different crises of behavioral health challenges can really kind of clearly see themselves, and it really does work. And so I'm just going to kind of talk from this space. The first part is reminding oneself. I went totally blank there. The first part is actually where I am telling my supporters, my care providers, or anyone else who I am when I'm well. Because who I show up in the place of crisis is not who I am when I'm well. And if you don't know me, all you see is the person who's yelling at you, the person who's not had a bath for many days, the person who may have self-injured, all of these things. You're not seeing who I am right here in front of you right now, right? The crisis plan gets written for the persons who may see it in the place of crisis. And so I'm kind of a person with story. If y'all will kind of give me that space, and I'll kind of walk you through an actual place where I activated the plan and kind of how that worked for me. It took me a while to actually create my crisis plan because I was afraid. I was afraid if I like put this in place that something was going to happen. But I was more afraid that it was going to happen. And I started asking supporters, I started looking at things, I started exploring for myself. And it took me a few weeks, months to actually kind of like initially get all the way through, but it took me another number of months to get it where it really, really fit. Because I had to look at what were the signs I needed my supporters to do to take over my care. Because I am saying here, I am telling you that if you're seeing this, like I'm not taking a shower for 5 days. I'm not showing up to work for 3 days and I haven't called anybody. You're coming in my house and all you see is me eating frozen food. Very clear signs that others can see, not what's actually going in here, but what can you see out here? It took me a while to figure that out. But I actually asked others what did they see, and in that was able to create something that really worked. What do I want my supporters to do? Well, in the past, when I would be in a place of unwellness, and I would be in a space, people didn't know what to do. They didn't know how to support me. They didn't know what worked or what didn't work. Because I'm someone who's experienced a lot of history of seclusion, restraints. So if I'm in a place of crisis, even though you may want to comfort me if I'm crying a lot, it really doesn't work for me. And so I put that in that place so my supporters know what works and what doesn't, what's helpful, what's not, what activities I may need them to take over. Like, do I need you to take over my bank account and pay my bills? And making sure they have the passwords, because historically I may have ended up with hot checks and lots of warrants for my arrest because I had a whole thing where I was spending all the money because I wasn't going to be here. I get to take agency even in the place of crisis. The last time I actually went into a place of crisis, I didn't really see it coming. It kind of hit fairly fast, and persons around me on the back end were able to point out some of the things they saw, but I hadn't shared with them what it might look like when things are breaking down for me. But my supporters knew what to do and to activate the plan when those things, kind of like what I just shared, went into place. And I made sure that those supporters that were a part of that were seeing me pretty much every day, were around me pretty closely, because I had persons on my plan that didn't live in the town I lived. So they wouldn't be seeing those things. So I made sure that I had people there. When it was activated, they had phone numbers to call other supporters because I had stated this is their number and this is what they're going to do. And with that, they called my cousin, who's a nurse, who came and stayed with me. And she's a nurse specifically because when I get in a place of crisis, or what it showed up to be, oftentimes I'd have to take some emergency medication, some medication that was of a higher level that I had already talked with my doctor, and I felt safe with her being there and doing that. So she came. That happened. She knew what to do. Other people, instead of feeling like they were really at a loss, they didn't know what to help or how to impact things, they knew what to do. And I also had a person, if people disagreed, who would step in. The other thing is having people in there that I didn't want involved. Like, I didn't want my father involved just because he's not supportive when I was in a place of crisis, and calling him, and he was my direct relative, wasn't going to be helpful. And it actually was just going to be more impactful. And so putting the why, putting who it is, having that why, me stating, please do not do this, was really important to me. Once again, what are the things that support me to get back to my wellness? So I'm talking about not that crisis is the end place. I'm talking about even through the place of crisis, that I know that I'm going to get back to this space of wellness. And here are the things that I need you to do. I had people who would drive me around in the car just for a drive. I had persons who would stay with me, right? I had people who would bring food that was specific food, and they would give it to me a very specific way. Because for me, when a lot of times when I got unwell, I thought my food was poisoned. So I wasn't having to worry or navigate this fear that my food was poisoned, because they already knew what to do and how to do it. And tasks. I can't tell you how many times when I've gone into the place of crisis, I would come out of a hospitalization and all my belongings would be gone. I can't tell you how many times I would go into a place of crisis and I would come back and I didn't have a bed to come back to, or I didn't have funds to come back to, or I had warrants for my arrest. I had a puppy dog. I needed someone to make sure that someone was going to feed my puppy dog, right? And there was a certain person who was going to do that, who was going to mow my yard, because they weren't emotional supporters, but they could do that, right? And most importantly, I get to tell you what it looks like when I'm coming out of crisis, when I can start taking some agency and start taking over some of the steps for my care. Because it doesn't look like I'm all well and things are sunshiny bright. But I know, because I know myself and what I've learned about myself, that I can start taking steps, even if they're limited, at this point. Having this plan supported me and has supported me specifically around being able to like hold on with this constant fear that I was going to go in the hole and never come back. That the things people said that I would, end up in institutions the rest of my life, that somehow I was faking everybody out at that point in my head, right? That didn't have to be the case. That I could travel the world because I had created this plan that supported me out living life. And people knew who I was with at the different times, what I would need should something happen, including certain medications that didn't work or made things worse, or treatments that didn't work or made things worse. There's nothing, I can't explain the feeling of knowing that your voice can be heard when you've been voiceless. And the last time I went into a really deep space, I was in it and back at work less than, like, it was like a week and a half. I wasn't hospitalized. I wasn't institutionalized. I didn't lose my self-worth. I didn't lose all of these things. What I learned and knew was that I was stronger than I thought. Because there's a second part which goes into the post-crisis plan, and that's looking at what works, what do I need to clean up. But it's also like looking and really giving yourself like that credit. But it's reviewing my plan prior to that to see where were there holes. And I had some holes where I didn't want to tell people some things because I didn't want them to worry that I was going to get sick again. And I told them afterwards, let me just put it that way. So if we look at RAP as a whole, we look at the crisis plan, that's how it's formulated to be implemented, right? And shared with care providers should the person choose, shared with their supporters should they choose. And I've seen it work over and over. It's an incredible tool too that peer specialists can use with people, alongside people or other clinicians, but it always has to be done in a mutual space, because RAP is based on a set of values and ethics that, include, it's always mutual, right? It's always voluntary, and a number of other things. I guess I'm like, Amy, I was like, why did I do this? Because I kind of ended on a little bit of a negative, but there's some pitfalls I think I really want people to think about and be aware of. A lot of people have called RAP over the years what is called crap rap. And it gets called crap rap. I hate you saying that, but that's what it's called, because persons have not been trained as facilitators. They may get the material and they give it to people, and it's just kind of a flat piece of paper. It doesn't have all the conversations. It doesn't have the exploring. Even if it's even just looking at the crisis plan, there's a lot of things that go into it versus just those questions. There's a lot of place where you support persons in their own agency. And so it shows up as something that's not very helpful at times, but it clicks a box in the EHR and it stays there and doesn't get used. Once again, people think they have to do it because it's presented like as something, as another sheet you have to fill out. The other thing that happens and has happened, I've seen with peer specialists, is, this is a quote with somebody I was talking to just last week or the week before, is as peer specialists, they were asked to do this with people and they were just given the crisis plan, not having trained it, not having gone through it. And their feeling was that they were setting people up to be unwell, basically stating that you need to do this because you're going to go into a place of crisis. I don't know if somebody's going to went into crisis, right? But it comes across that way. So if you start looking at RAP or utilizing RAP in your organization, these are just some things to think about. And once again, I know I am very biased about this work and about what it's done in my own life, but also what I've seen across the years. So the work within the crisis plan and RAP builds on all these things. And the coolest part is that it actually can inform a person, inform and bring in information into a person creating their advanced directive, creating this legal binding document. So kind of with that, I'm going to send it over to you, Dr. Schwartz. And yeah, that's wrap. That's a wrap with wrap.
Well, thanks very much. I'm Marvin Schwartz. I'm a psychiatrist, and for many years worked in a variety of different clinical settings, and have done research on various interventions for persons with severe mental illness. And for several years, we've been interested in psychiatric advanced directives and how to implement them, how they work, their effectiveness. And we operate a National Resource Center for Psychiatric Advanced Directives, in which we try to keep up with and collate for people what's going on in states with psychiatric advanced directives. Next, please. Next, please. So what are they? And one of the things I'd like to say is that these are not mutually exclusive approaches. So what Dan was talking about and what Amy was talking about are things that are not mutually exclusive with PADS. Let's just call them PADS. And in fact, when we work with people, if they have a RAP plan or other plan, we work to integrate them into the psychiatric advanced directive. So they're different, but the ideas are common, and they can be used together. So what is a psychiatric advanced directive? It's a legal document that allows a person, when of sound mind, so that has air quotes around it, to refuse or give consent to future psychiatric treatment. So that's one component of it, the advanced instructions. Those are the instructions themselves, which in a RAP plan would be what generally the things that you gave as instructions. Now I have quotes around of sound mind because the law requires that the person have capacity to make these instructions at the time that they do them. And that's the same standard as in making a will or other things. It's called testamentary capacity. The other part is the healthcare power of attorney, which allows one to appoint another person, a trusted person, to make future decisions about mental health care on one's behalf if incapacitated. So that person, in effect, becomes a crisis navigator at a time when the person is unable to speak for themselves. And we think that having these two things together, if the person wishes to, and they have someone that they trust, is the most effective way to do this, because it allows, if you do an advanced instruction, you're not going to be able to put every contingency on paper, just like with a medical advanced directive. And so what the healthcare power of attorney, or what the healthcare agent, that's the person who serves in that capacity, is able to do is to interpret the preferences of that person and flesh them out, and also to talk to providers and reinforce what's in the advanced directive. The person who serves as the healthcare power of attorney has to be on the same page as the person who made the advanced instructions. it's their job merely to interpret or to consent to treatment or interventions that the person would want if they were able to speak for themselves. Next, please. So again, there's two pieces: the advanced instructions, which is similar to a living will, which documents the person's wishes, consent, or refusal of future care. And then the healthcare power of attorney, which appoints another person to make decisions during crises. And that person can be designated to have broad powers or limited powers. So for example, if you have no reservations about what that person ought to be able to consent to, then you would not put any limiting notations on the healthcare power of attorney form. But if, for example, you don't want that person to have the ability to consent, say, to hospital admission, you could do that. And so you can design it that way. In North Carolina, these are two separate legal pieces or documents, and you can have either or both. But again, we encourage people to have both. Now, not every state has this standalone psychiatric advance directive, but in the states that don't have that, and I think there's now 27 states that have psychiatric advance directives, you can do this under the general healthcare power of attorney living will section, although some states will limit what you can do there. So in some states, I think I was speaking to people from Delaware, and their current healthcare power of attorney limits the authority of that person to make certain psychiatric decisions. Now, one of the things that's different about this in most states, an important caveat, is that it's a self-binding document, in that during the period of incapacity, so when the person's in crisis and can't speak for themselves or has an inability to make decisions, the psychiatric advance directive is in effect and can't be undone. So the person binds themselves to the choices they make in the advance directive. And this is something that some people don't like, that they don't like the binding nature of it. But it was designed to have this feature by advocates who thought that there are times when people make bad decisions in crisis, and this is a mechanism when the person's able to think clearly, and in a moment of reflection, they're able to make a set of decisions that they do want to bind themselves to. Now, there is at least one state that allows you to have a non-binding advance directive, and I think that's the state of Washington, where when you do it in the state of Washington, you can stipulate whether it's going to be a binding pad or not. But I will say this is one controversial aspect of it that's present in most states. Next, please. So several years ago, with the MacArthur Network on mandated community treatment, so in 2004, we did a survey in mental health clinics across the country within these states: Chicago, Durham, in these cities: Chicago, Durham, San Francisco, Tampa, and Worcester. And in those clinics, we asked the following questions. So these were folks getting care. And we said, have you completed a mental health advance instruction or appointed a healthcare agent? And you'll see very few people had. There's one anomaly in Tampa, but generally about 4 or 5% of people had completed one. Next. However, when we asked the next question, would you want to complete a PAD if someone showed you how and helped you do it? Next. Then we see that about 2/3 to 3/4 of people asked said yes, they would like to have one. So there's a huge latent demand, at least in 2004, or for to have a pad. And there's a big gap between how many people who have them and how many people would like them. And we've written a fair amount about the barriers to completing pads. And one of the big ones is that they're written in a way that's not particularly accessible. They're kind of legalistic. When you read it, you might not really know what you're doing if you do it on your own. And we really believe that people need help, that we need services from different organizations that can help people complete them. Because one, few people complete them on their own, and two, they're hard to understand without some background and guidance. And so we've worked with different organizations to try to build capacity for them to provide that service. So we've worked with peer support organizations in North Carolina, and that was very successful. And we also worked with several NAMI chapters, and that was successful too. Although I would say the peer organization just was able to devote more resources to it. Now, some people, would prefer one over the other, but we think, the solution is to put it out there and you can make a choice about who will facilitate them. Next. What the PAD does is it usually permits the individual to plan for, consent, or refuse just anything they could consent to in person. So that would include hospital admission, medications, even ECT, or other mental health treatments. But it only takes effect in the event the individual loses the ability to make decisions and is incapable. Next. So what's that mean? What is incapacity? So it is not incompetency. And it's a very important distinction. Incompetency is a legal adjudication. A person's is in court or is represented in court, and a judge using documentation, information that he or she gets, makes a decision about the person's competency and usually appoints a guardian. This is an informal bedside clinical decision in which, as you see here, in the opinion of a physician or eligible psychologist, the person currently lacks sufficient understanding or capacity to make and communicate mental health treatment decisions. That's the threshold. When that gets written in someone's medical record, from that time until the physician or psychologist writes the person's regained capacity, that person is deemed to be incapable, and at that point should not be asked to make any decisions about treatment, that either the document takes over or the healthcare agent takes over. Now, these definitions obviously differ some across states, but the core issue here is it's a bedside determination. It's written in the chart by the provider. The person in their PAD can select which provider will make that determination if that's feasible. But during that period of incapacity, the PAD is activated, as we say. Next. So how do you do it? Any person of sound mind can do it, can complete the form. Even though there are forms generally in the states, one usually is not bound by the form as long as the document contains the information needed. For example, in most states, witnesses and notarization. So it's signed in the presence of two witnesses, not a relative. The person can't be a relative. It can't be someone who potentially has a conflict of interest, can't be a staff member of a healthcare facility or a provider. And then usually in most states, it has to be notarized. And then the person can put it wherever he or she thinks it will be most effective. So give it to the doctor or the mental health treatment providers or the hospitals where they go. And then in some states, there are actually repositories where you can post them and put them so that they're available on demand. Now, with the evolution of electronic records, we generally recommend that people put them in their electronic record if they're part of a health system, because those tend to communicate in their known place to find them. Next. So one of the big questions is, does the doctor or the health care provider have to follow the PAD? And the answer is, there are situations in which the clinician may disregard the instructions. It's very important for the person completing it to understand that. One condition in which the clinician can disregard it is if it's not consistent with generally accepted community practice standards. So if the person requests something that for example, the doctor thinks might be harmful or is outdated, because sometimes you have a PAD on file, but say you developed an allergy to that medication, you wouldn't want the clinician to do that. So they can disregard it if it's not consistent with generally accepted community practice standards. When the treatment request is not feasible or unavailable. For example, if I requested to go to X hospital and that hospital was full or wouldn't take me, well, that request can be overridden. Or when the treatment request would interfere with treating an emergency, or can be overridden by involuntary commitment or conflicts generally with the law. Now, that may seem like there's a lot of conditions to to disregard the PAD, but they're really sort of practical reasons why the PAD might be overridden. And it's a way for clinicians to accept and not feel threatened by this sort of evolving practice. Next. So when does it take effect? As I said, it takes effect when the person's deemed to be incapable and continues during that period of incapacity. That's very important because while the PAD might give guidance when the person's not in a crisis, and it's a very valuable document because when they're well constructed, they're a great précis of someone's history. And sometimes there's just too much documentation and too much for people to read, say, in an emergency room. To do a full chart review sometimes isn't feasible. And one of the great things about a PAD is that it's a very concise, précis of someone's treatment history, if it's written well. And when we work with people, that's what we do. We try to write a document that's going to be written and is concise and to the point. But it only takes effect when it's written in the chart that the patient or the person's incapable. Next. So similarly, the healthcare power of attorney takes effect during a period of incapacity, not before and not after. But we really think that that's a person who can be an effective crisis navigator if the person, making the PAD feels that they have someone they trust. And unfortunately, in the studies we've done with people and helping them do PADs, there's a lot of folks we've worked with who just don't have someone in their support network that they feel comfortable making decisions for them. Now, we do work with them and say, it doesn't have to be your mother or your significant other. It can be someone else. But still, even working with people, there are a significant number of folks who just don't feel there's someone who they can trust to carry out their wishes. And that's unfortunate because we really think that the advanced instructions is just sort of a flat document that doesn't do enough to speak to providers without someone interpreting. But those are the limitations, and there are some people who just don't have someone that they want to trust. Now, you can read a lot more about this. We operate this website called NRCPAD, National Resource Center on Psychiatric Advanced Directives, in which we'll show you state by state what your law is. We have the forms there. God willing, we have all our links working correctly. So we think it's a good resource. There's a lot of other education materials. But there's all these other places listed here where you can go and get information if you're interested. So thanks very much. I hope you're interested in this area.
Let me just say a couple of quick things, then we'll have some time for Q&A. First of all, just really a huge thank you to all three of you. I try, given my own areas of interest, to stay generally informed about these tools and strategies, but I learned something new from each of you today just in the last hour and a half here. I also am thinking, like years ago, back in the day when I was doing my own clinical work, I remember I had an experience. This was long before I'd heard about RAP planning or safety planning or advanced directives. And I remember I was supporting someone who entered into a crisis and got stuck in an emergency room waiting for a bed for admission and was in a hallway for 2 days with no privacy and complete chaos. And even as an external supporter, I remember just thinking like and feeling how traumatic that environment was. And I can only imagine how traumatic it was for him. But I remember at the time, even before I knew about these tools, like, I wish I had known what to say to the doctors and the people in the ER. I wish I had known what I could do to make you more comfortable, like bring a deck of cards and play cards with you, or bring a favorite blanket or a sandwich or whatever it might be. Or like, do I need to take care of your dog or get somebody to take care of your dog at home, like Amy was saying, and just how that would have sort of given me the tools to be a better advocate and a better supporter. So thank you for your comments today, and thank you just for your work in general in this space. I tried to follow your lead advancing the slides. I apologize. I didn't realize how hard it is to juggle the chat box and advancing the slides with all my windows open. So there's a couple of delays there. But let me just double check. Let me see if there are questions that came into the chat. One question, and also just kind of comes up in general. Maybe Amy, Dr. Schwartz, could you maybe talk about sort of the relationship between a RAP plan and an advanced directive, and in particular, sort of how are they different? Because there is a lot of overlap and similarity, but there's sort of a step beyond with the legal aspect, is my understanding, with the advanced directives, and it might be helpful to clarify that a bit.
Yeah, early on with RAP, they used to state that if you signed it kind of with two people, it would be an advanced directive, which, you know, is not the case. The legal aspect is the big one. And like Dr. Schwartz was saying, there's a lot of different legalese within that psychiatric advanced directive, whereas in the RAP, like crisis plan, it's your words, using your words, stating things through your language. There's a template that you're using, right, with the different questions and the different parts. And there's some things on the psychiatric advanced directive that it asks for that are not included in the crisis plan. But I've worked with a number of people in creating their crisis plan who then really wanted to go on to create an advanced directive. And not my area, like it's just not my expertise. And thankfully in Texas, we've had an organization who's worked with a lot of persons in creating those psychiatric advanced directives. And so, you know, being able to then give them that tool of a resource to go to with someone who could then help put it in the format that Texas requires, right? They actually would also do the notary and those type of things. But what my conversations with some of the people at Rio Grande Legal Aid were that when people did come in with a RAP crisis plan, or even like their whole plan, when they came into them, they were able to really express what they needed and what they wanted in a way that they didn't see with a lot of people who just came in and went straight to the pad. Not a right wrong. It's just something that they kind of noticed along the way.
So we do, if a person has a RAP plan, we do encourage them to sort of populate the psychiatric advance directive with the RAP plan. The step beyond the legal piece that is important about the PAD is, and this goes back to the remarks that Dan was making, is if a person can't consent or seems to be, at risk of further decompensation, what the PAD does is it allows you, the document will serve, or the person who serves in the health as a healthcare power of attorney has the authority to consent to admission. And so one of the things we've really tried to emphasize with people is that this is a way to reduce involuntary commitment among people who can't consent. It's very a provider is forbidden by law to take a voluntary consent from a person who is incapable.
Yeah.
Supreme Court said that if a person isn't able to give informed consent, then you cannot admit them voluntarily. So this is a mechanism to avoid involuntary commitment, to avoid a police pickup, to avoid riding in a police car, unfortunately often in handcuffs. So that's a big advantage. There's also the advantage, I think, I'm not saying they're mutually exclusive in any way. I'd encourage people to do both. But the other thing is that we've heard from a lot of people that they feel that this is very empowering to have an advance directive, that they feel that they sort of have the weight on the law of the law behind their decision making. Now, the other thing I should have said that we do is when we facilitate them, we sort of reality test with people because we don't want people to be disappointed.
Yeah.
So I'll give you sort of a trivial example, but a one that illustrates it. We had one person who said, I want to put in my pad that when I'm in the emergency room, I want to smoke. I want to smoke a cigarette. And so what our facilitator did and what they, instructed to do was to say, we understand, but we don't know of an emergency room that's going to allow you to smoke. And so you have the God-given right to write this in this pad, but it's just going to disappoint you. And you're just going to lose confidence in this thing because it's going to be instantly overridden. So we try not to, try to reality test so people don't have expectations that are unrealistic, and try to, talk about, well, what the realities are of, crisis care, good and, for good or for bad.
Someone once said to me, I'll check this out with you, that one way to sort of think about it is that you can write whatever you want in your advance directive, but having an advance directive doesn't give you any more rights than if you didn't have one, for example. So like, if it is like a policy that you couldn't smoke, for example, in an emergency room, any general patient, that's not necessarily going to be honored. So that was one. Does that kind of make some sense?
Yeah, that's important. That's a good way to frame it, and important. And sometimes there is a little misunderstanding where people, when they do a pad, think it's an entitlement to a treatment plan, and it isn't.
Right.
No, that's not the way medical care works. You have to have an agreement with the provider about, what the treatment plan is. So writing it down doesn't make it happen.
Right. And I'm not sure, this may be a question for you, Dr. Schwartz, but when we were organizing this webinar, I also wanted to make sure that in terms of our audience and our stakeholders, like obviously we see all the things that Dan, Amy, that you shared today as fitting with sort of a person-centered recovery-oriented framework, right? Being the right thing to do. But when you start talking about advanced directives, it's not just the right thing to do. There are some legal guidelines that we have to give people the right to complete one of these. Like, I think as you were saying, like one of your first bullets on one of your slides said it's a legal document. And even if a state doesn't have a specific psychiatric advance directives, people have the ability to create a medical advance directive that could still shape their care. So I'm just wondering if you could just say a couple of words, you know, sort of the patient self-determination kind of legal foundation.
Right. So arising out of the Supreme Court decision in the 1990, Congress passed the Patient Self-Determination Act that said that any facility that accepts federal funds, so essentially Medicaid and Medicare, has to ask the patient if they have an advance directive. If the person has it, they have to put it on the chart. If a person does not have one, they have to give them guidance about how to complete one. That is a so-called condition of participation. So a facility that doesn't do, and that's why if you've been admitted to the hospital since 1992, they ask you that. Do you have an advance directive? Because it is, it's a condition for that facility to, you know, get paid for Medicaid and Medicare services. So yeah, it is a right. Unfortunately, enforcement of that is based on complaints.
Yeah.
So, and I don't think there's that many complaints about it. You would hope that JCHO, when they survey hospitals, would look at it more clearly, you know, closely. They really don't. We've talked to them about it. But so it would only be based on a complaint that a hospital would be surveyed or, you know, investigated if they failed to do that. But I would say that when that happens, all hell breaks loose in the hospital, and they probably wouldn't do it again.
Yeah.
Because it's quite a thing when the regulators come to it, you know, to survey you.
I think it brings us full circle to a point that you made earlier. Your data was so powerful in that slide. Like, these are tools that are available, but they're like grossly underutilized, right? So you mentioned the importance of people don't know what they don't know. And if they don't know they have a right to complete one of these, then that also, I think, sort of bleeds into the enforcement because they don't know perhaps that something wasn't honored. And I appreciated that you mentioned kind of the power of involving peer support in that project in North Carolina to really educate and build awareness about.
Yeah, I would also say that, you know, there are a lot of barriers to PADS and their uptake. And one of the big ones, going back to Dan's comment, I think, is that health systems have become so risk averse that their instinct is to involuntarily commit people. And, you know, we need to educate health systems that they don't need to be so risk averse. They can take a chance on person-centered care.
I can think of no better phrase to end the webinar on today. Let me just remind our participants, our slides and the webinar recording are typically posted on the website about a week after an event. You saw that we consolidated all of the resources and the links from today's event into a slide. And if you would please use the QR code on the screen or a link that Christine is going to drop into the chat. We really do appreciate your feedback. We use it to shape the remaining events in this webinar series, and it's really very practical to us. So again, a very big thank you to all three of you, not just for today, but for all the good work in this space over many, many years. This has been a terrific addition to our webinar series. So thank you to all of you, deepest appreciation, and we will go ahead and sign off, and I hope everyone enjoys the rest of the afternoon.
Thanks for having us.
Take care,
Thank you.
everyone.